Good day. My name is Allan Rogol, and today we will speak about idiopathic short stature, ISS, its definition, diagnosis, and dilemma about pharmacologic therapies. Disclosures. I have consulting agreements or a board member with the following companies, and in full disclosure, I also have ISS. Today we will speak about criteria and clinical features, evaluation of the short child, considerations for growth hormone therapy, and then considerations for additional or alternative therapies. Treatment of children and adolescents with recombinant growth hormone for the indication ISS is controversial. Growth response is highly variable, and there is little evidence that short stature represents a substantial psychological burden to most short children. ISS is a clinical description rather than a specific disease. It is height below 2SD, 2.3rd percentile of the mean for age in the absence of any endocrine, metabolic, or other disease or syndrome that explains the short stature. Idiopathic short stature by the FDA criteria, these are the criteria that are needed for therapy with growth hormone. Height SDS less than minus 2.25, associated with growth rate unlikely to permit attainment of adult height within the normal range. For a male, below 160 centimeters, for a female, below 150 centimeters. In addition, there would be normal intrauterine growth, absence of underlying disease, psychiatric illness, genetic abnormality, normal weight for height with a good appetite, a good caloric intake, normal body proportions, and normal GH. As an indication for children with ISS, there are expectations. When considering GH therapy, it is essential to establish realistic expectations, since unmet ones can have their own untoward effects. Children presenting for growth hormone therapy and their parents often believe that treatment will make them of average height or taller than average. However, even if the treatment is successful, most patients will still be short as adults. For example, if a boy's predicted adult height is 155 centimeters and GH therapy is successful in adding 5 centimeters to that, the adult height will be 160 centimeters minus 2.25 SDs at the 1.2 percentile, and that is the upper limit for treatment of children with ISS. It is considered a normal variant. Other normal variants include familial short stature, constitutional delay of growth, and puberty, but these are all so common that there's considerable overlap among these variants, and many healthy children with short stature have growth characteristics that are consistent with more than one of these categories. What are the oxalogic and endocrine findings? Normal height velocity, but usually at the lower end of the normal range. No biochemical or other evidence for specific growth restricting conditions, and we'll come back to that. Normal results on a growth hormone stimulation test. They may have a relatively low level of IGF-1 in combination with a normal or actually slightly high level of human growth hormone, meaning that they are a bit or may be a bit GH resistant. This finding is far more common for children with an intercurrent, especially chronic illness, and that's why it's so important to take a proper medical history. The issue is often how comprehensive the evaluation is going to be in the absence of pathologic findings from the medical history, the family history, physical exam, and preliminary laboratory data, which may only include the bone age. There is a low incidence of pathology detection and a high cost of screening in the evaluation of asymptomatic short children. I will go over that particular paper, and what is an appropriate evaluation is the editorial that I wrote almost a decade ago for this particular problem. So, in otherwise healthy children, the yield of additional laboratory testing is extremely low. And if you look at, these are now old data, but if you look at the relation between height and the frequency of organic disease thought to account for that, notice that one needs to be well below -2 SDs, in fact, below -3 SDs, before the numbers become quite significant that an organic disease will be found. These are absolutely recent data. You'll notice that it's August 2020. These are a very important set of data. The etiology of severe short stature, notice that the height is less than -3 SD at greater than 3 years of age. It is completely color-coded, that you can see in the key on your right. But notice for girls and boys that at -3 SD and more, ISS is a significant chunk of these children, and you'll notice also syndromes, which are the more pink. That's the overall group of kids who are below -3 SDs. And you will see on the horizontal axis a number of conditions for which children are below -3 SD, and you will notice for most of them they are relatively close to -3 SDs. It's only when you get to syndromes and skeletal dysplasias that you see quite severely short children and a very much bigger range within that heights within that group. Organ system disorder really has more to do with how severe it is, whether it's severe chronic kidney disease, whether it's severe liver disease. Now is the important slide that shows the distribution of causes of short stature by severity. We are now talking about all the kids below -3 SD, but please note, starting on your left, going toward your right, that they go from -3 to -3.5, that's the leftmost, all the way up to greater than below -5 SDs. And the biggest thing that you will notice is the bottom in the key, ISS, the blue hatched area, gets smaller and smaller, and the pink, which is syndromes, and the green, which is skeletal dysplasias, become more common as the kids are shorter and shorter and shorter. So, in the evaluation of the short child, height velocity from serial measurements, these are all n=1 experiments, interpretation of the child's growth trajectory in the context of the parental heights, mid-parental height being important, bone age to permit an estimate of adult height, that is, what growth potential is left, moderate accuracy but wide 95% confidence interval, look for skeletal dysplasia in the bones of the hand, wrist, and forearm, note body proportions. Now, one of the biggest things that the children, but especially their parents, bring up is that this short stature business is a psychological disaster. What are the data? Population-based samples show no differences in psychological functioning between those short and those within normal limits for height. Negative stereotypes regarding the social adjustment of individuals were similar in both groups. And these are data mainly from David Sandberg, and you can note the references in the lower right. In those children, short stature could not be established as the cause of the disturbance. Now we switched from population to clinic-based populations, and they often have more externalizing behavior problems and poorer social skills. That is, the children referred for possible medical treatment for short stature likely represent a population selected for a higher level of parental or child concern. These are now the data from the study I mentioned previously from Cincinnati, in which they evaluated short children and the workup that they did for them. This is the consort plot, but it's really important because you'll note that there were more than 1,300 new patients coded for short stature. This was a retrospective chart review. 1,138, that's a huge percentage, were excluded because more than half weren't short at all. Prior growth velocity, less than 5 centimeters a year, that is abnormally slow height velocity. History review of symptoms or physical exam suggest an underlying diagnosis. So idiopathic short stature doesn't count because they really do have a diagnosis and a significant number of incomplete medical charts. That leaves 235 patients, which is some 15 to 20%. You will note that 98% of them without pathologic diagnosis, 23% had familial short stature, 41% constitutional delay, and 36% ISS. Look on the other side, they found 3 diseases. They found one with celiac disease, someone who had an abnormal TTG but wasn't biopsied, and a possible IGF-1 receptor defect lost to follow-up. But what is important is that if you looked at just their heights, it wouldn't be terribly helpful. If you look at the age in which at A, look at the age, the CDGP or CDGM children were a bit older, but if you look at the height at B, they were virtually all the same height except the other, and that will include the skeletal dysplasias, which shouldn't surprise you given what I showed you in that multicolored slide. The target height SDS for the familial short statures should be smaller than all the others, but please note for the CDGM, that is maturation instead of puberty, ISS and other, their target heights are well below 0. The height deficit is again the least in the familial short statures because they're supposed to be small. The other ones have a height deficit of more than a standard deviation. Weight, most of them are also underweight for age, but mostly appropriate weight for their height. And in the other, they are again they weigh less. And the bone age delay is big time in the CDGM, much less in the FSS, and intermediate in the ISS and the others. This one should get your eye. So to do all the tests that we as PES and as others suggested we do, you would spend a whole lot of money. This is what things cost, and you come up with 3 diagnoses, meaning one would spend in 2013 dollars over $100,000 per diagnosis. That's why you should do a very truncated workup and follow the patient, because if there are no signs or symptoms related that might be related to an individual condition, and see what happens. So, what about growth hormone therapy? Guidelines, including those from the Pediatric Endo Society, recommend against the routine prescription of RHGH for every child with ISS. Note the every child. Practical solutions: carefully rule out constitutional delay of growth and puberty. Counseling for the family about the real impact of ISS, keeping in mind that your patient is an individual. Remember I said before, this is almost an N=1 experiment. Limitations and uncertainties, little evidence that short stature has consistent detrimental psychosocial effects. That's what I was getting at on the slide when we talked about the psychosocial aspects. Moderate efficacy, I'll show you a bit of data, and substantial inter-individual variability. That is, some kids grow very, very little on HGH, and it is the rare child who will have a growth spurt on RHGH comparable to one who is actually tested as growth hormone deficient. And again, it should be of no surprise to establish realistic expectations. And this is a really important point because this is where one ought to, as a subspecialist, sit down with the patient and carefully go over the expectations. Remember, these patients are patients of a primary care doc, and you wish I presume, to co-manage these patients, give them the appropriate expectations, and then I think the kid's life, the parent's life, the referring doc's life, and your life will be a whole lot easier. What are the expectations? Alterations in height velocity are most often below those of patients with growth hormone deficiency, and predicted adult height gain is small, usually meaning the child will remain small, but perhaps not so much in the relative sense. At the first discussion of growth hormone therapy, one should note the wide range of responses, including no response. That should lead to a discussion of essentially, again, an N=1 clinical trial. For example, if the child does not grow at least 2.5 centimeters per year more than before therapy, the therapy is considered futile and should stop at the end of 1 year. That won't happen unless you preemptively talk to the patient about that at the consultation. Patient characteristics that predict a greater response to RHGH in children with ISS. Height at the start of treatment, taller is better. Age at the start of treatment, younger is better. Height response during the first year of therapy, greater is better, and that is a very important point, and mid-parental height being taller. It's just like in dogs. Scotty dogs have Scotty dog puppies, and Great Danes have Great Dane puppies. Growth hormone therapy at the standard doses appears to have minimal physiologic adverse events. One early on needs to be concerned about idiopathic intracranial hypertension. Usually that's due to the retention of salt and water as the kidneys are learning how to deal with growth hormone. Increased intraocular pressure from the same business. Reduced insulin sensitivity. Growth hormone is an anti-insulin compound. Slip capsule femoral epiphysis, that usually, it's rare, but it usually occurs after a year or more, and worsening of existing scoliosis. Anytime one grows, scoliosis would get worse. All studies that have looked at these are underpowered to detect rare adverse events, have limited length of follow-up, and use a variety of dosing schemes, making it very difficult to determine the exact longer-term side effects. The shorter-term ones, especially idiopathic intracranial hypertension, while rare, is quite significant, and that is something that should be discussed before starting the first injection of growth hormone. Dosing of growth hormone. There are a number of approaches. This is one that I use. One approach is 0.24 to 0.3 milligrams per kilo per week, which turns out to be 35 to 43 micrograms per kilo per day. Measure IGF-1 at 1 month. I do that before you can even measure any growth effect. One for safety, to be sure it's not above +2 SD. The other for efficacy. If it's still below 0 SD, I would increase the dose of growth hormone at 1 month rather than waiting for 3 to see that the kid isn't growing at all, and then adjust the dose if necessary, either up if it's seemingly in that IGF is in the inefficacious range, or lower it if the IGF is above +2. Measure patient and IGF-1 at 3 monthly intervals for 1 year and adjust dose mainly based on height velocity. So now we're getting away from IGF-1 levels and seeing how it affects the biology, the physiology of the patient herself or himself. After 1 year, a second bone age determination, as well as a decision to move to a second year or stop. Move to a second year if the height velocity is more than 2.5 centimeters above what it was previously, or stop if it is not. Additional or alternative therapies. Sex hormones only for those with delayed bone age, and again, one might have ISS and CDGP. In some of the slides it was CDGM, P for puberty, M for maturation. Aromatase inhibitors, to delay epiphyseal closure, boys only obviously, and the data are mixed, and there have been some questions about whether there are bony deformities caused by aromatase inhibitors. GnRH analogs to delay puberty and epiphyseal closure, essentially working in a similar manner to the aromatase inhibitors, but here they block all sex hormones, whereas the aromatase inhibitors would permit puberty to go on. IGF-1, been thought about, been looked at. It is questionable whether that would be the appropriate drug to use. Now, what about the height outcomes? This is a screenshot from up to date that Eric Richmond and I wrote and just very recently updated. These are not all of the studies. These are the studies that show the height gain, the therapy mean, the mean number of years. There was adult height noted, and just a couple of comments. So in a meta-analysis by Finkelstein in 2002, the height gain was 4 to 6 centimeters. Notice the therapy, 5 years. Adult height was measured, and short stature was defined as stature less than 10th centile. So some of these kids would not have fit the FDA definition of ISS, and there were a large number of patients being over 1,000. Another meta-analysis in 2011 was a gain in the same range, again over 5 years. Adult height was measured, but only a small number were included because the Deodati analysis only looked at randomized trials. So most of the Finkelstein trials had no control group. Counts in a randomized controlled trial noticed 8 centimeters, 1.3 SDS after 4 years. They didn't measure adult height, and the height gain was calculated by the height SDS change from baseline to the end of study. Height gain was similar for both treatment groups, that is, both doses, and randomization was to compare 2 different treatment regimens rather than compare growth hormone with an untreated control group. So the height gain of 8 centimeters does not fit with the others, both in terms of its absolute value, but much more because it is a different study design. And then one other study from Lilly, was a prospective observational study. They noticed rather large height gains. Therapy was for a long period of time. Adult height was measured, but many patients with delayed bone age were included. Spontaneous catch-up growth may have, and likely did, contribute to the height gain reported. So I believe height was gained by giving growth hormone, but I believe it is in fact quantitatively more than it would have been otherwise. Thank you.